So, welcome everyone today to this another walk-in series in our AIOS webinars. And this is a walk-in series today, walk-in retina patient, how to diagnose, treat, and when to refer. So, this is targeted to all the practitioners who want to know how they can diagnose, when is the limit to treat, and when they have to refer the case. The chairman of this session is Dr. Naresh Yadav, who heads the Retina Services at Narayan Nethralaya, Bangalore. He did his Retina Fellowship from Shankar Nethralaya, Chennai in 1998 and FRCS in 2006. He has over 50 publications in various national and international journals, and he has special interest in vitreomacular interface disorders and tractional retinal detachment surgeries. Rajesh, will you please?
It gives me great pleasure to introduce Dr. Dinesh Talwar, who obviously needs no introduction, and he's such a known retina surgeon. He's the director of retina and uvea services at Center for Sight, New Delhi. He is also an alumnus of AIMS, New Delhi, and has worked as additional professor of ophthalmology. Has got all the specialty training as well as the MBBS done from AIMS. He is currently associated with Apollo Indraprasth Hospitals and Center for Sight, New Delhi. Dr. Talwar has a special interest in surgical management of post-operative and post-traumatic endophthalmitis. He has edited 2 books, written 17 chapters in books, published more than 50 articles, and has a huge and a wonderful clinical acumen. We welcome you, sir.
I have with me my co-moderator, Dr. Rajesh Sinha, who is the honorary treasurer of All India Ophthalmological Society, as well as professor of ophthalmology at Cornea, Cataract and Refractive Surgery Services, RP Center, AIMS, New Delhi.
Yeah. We have with us Dr. Devendra Venkatramani, who is at the Lakshmi Eye Institute, Navi Mumbai. He is a vitreoretinal surgeon, very renowned. He completed his graduation from BJ Medical College, Pune, and Retina Fellowship from Shankar Nethralaya, Chennai. Dr. Venkatramani was associated with IIT Chennai as a project consultant, where he worked on the design of a mobile operating theater to perform cataract surgery. Dr. Venkatramani has clinical interests, including management of, which includes management of AMD, pediatric retinal disease, DME, and neuro-ophthalmology. We welcome you.
We have with us Dr. S.K. Chaudhary, who's Additional Chief Health Director, Northern Railway Central Hospital, Delhi. He's completed his graduation from Maulana Azad Medical College, Delhi, and his Retina Fellowship from RP Center for Ophthalmic Sciences, Delhi. Welcome, Dr. Chaudhary.
Thank you.
We have with us Lieutenant Colonel Dr. Pradeep Kumar, who is Associate Professor of Ophthalmology, Command Hospital, Chandi Mandir. He has spent 17 years in Army Medical Corps. He is a graduate from AFMC Pune and completed his Retina Fellowship from RP Center, New Delhi. He has authored more than 20 articles in various index journals. Dr. Pradeep is an adherent sports enthusiast representing swimming in zonal levels, bike expedition, squash, and many more. He's a wonderful friend as well. And when he was working at RP Center, we had wonderful time together. We welcome you.
Thank you, sir.
It is my pleasure to welcome Dr. Ramesh Venkatesh, who completed his graduation from JJ Medical College, Mumbai, and Retina Fellowship from Shankar Nethralaya, Chennai. He has a strong interest in retinal imaging, and he has published more than 95 articles in the peer-reviewed journals and 3 textbook chapters. And he's undergone glaucoma training program at Arvind Eye Hospital, Coimbatore. Welcome, Dr. Ramesh.
We also have with us Dr. Karthik Kumar, who is the assistant professor at the Retina Department, Arvind Eye Hospital, Madurai. He has 17 articles published in various peer-reviewed journals. Dr. Karthik has interests in diabetic retinopathy, ocular imaging, and diabetic vitrectomy. We welcome you, Dr. Karthik.
So, from here, we would request Dr. Dinesh Talwar, who's actually been our teacher also at RP Center, and we share some wonderful memories with him. Done several papers together, did DOS times together, and has learned so many things from him. I mean, he's an encyclopedia in himself. You can, as you watch him, imbibe so many things from him. So, over to Dr. Dinesh Talwar, sir, for now carrying over the proceedings of the webinar.
Thank you, Namrata. It's a pleasure to meet old friends and make new ones. even though it's on Zoom. And I think this is probably part of our new normal, which Namrata is trying to change into a physical format over the next few months. And I hope she's successful. So without further ado, let's start off. We have Dr. Naresh Yadav, who is going to be our controlling, presiding deity over here. So for all you people who are going to be speaking, please adhere to the discipline of your talks, because he's the one who's going to keep a watch on you. After each talk, we will have some discussion on the relevant topics. So if you stick to your time, which is around 15 minutes, we hope we'll have more time for discussion of each of these talks. So let's start off with the first thing. The most important thing is when a patient comes to your OPD, it doesn't matter if it's a retinal problem and he's come for a routine thing. Fine, let him come, you see him, you have enough time, you don't have to worry. The problem comes, sometimes that retina problem could be a harbinger of much grave prognosis, something lurking which is very, very dangerous to the life of the patient. And so we start with Mayday, the SOS call. You have a life-threatening disease presenting to you. How do you ensure you don't miss it? And we have over here Dr. Devendra Venkatramani, who's going to, over the next 15 minutes, explain to us what to do so that we don't miss a life-threatening situation. Over to you, Dr. Ramani.
Thank you so much, sir. It's really an honor and a privilege to be presenting to such a wonderful panel, as well as to the August All India Ophthalmic Society gathering. So I'll just be going through a few cases, but let's start with a little bit of an introduction to our topic. You know, the eyes are called the windows to the soul, but I really believe that the retina is really a window to the rest of the body. It's uniquely accessible, and it's the only part of the body where we can actually see the blood vessels, neurological tissue, and the underlying vascular choroid has the largest blood supply per 100 grams of tissue in any organ system of the entire body. So we can always boast to our non-ophthalmic colleagues that we really have something special within the eye. So needless to say, various vascular disorders can manifest within the retina, including diabetes, hypertension, hyperlipidemia, but also systemic vasculitis and infections, including HIV. Neuropsychiatric disorders are really of great interest in today's day and age, and some of these are areas of intense research, especially with regard to their retinal and optic nerve manifestations. Hematological disorders like malignancies, anemia, hemoglobinopathies, and hypercoagulable states can also leave their mark on the retina as well as other parts of the eye. So let's jump in and see this fundus image. This was a 42-year-old gentleman who complained of drop in vision in the left eye since about 15 days. And here you can see the classic picture of dot and blot hemorrhages scattered in all quadrants of the retina, a diagnosis that is not very difficult to make, but it warrants further investigation. And naturally, on further investigation, these were all the comorbid factors. In a 42-year-old gentleman who otherwise had no systemic complaints, we found him to be diabetic, hypertensive, and have hyperhomocystinemia. So this is a fairly run-of-the-mill situation that one encounters in day-to-day practice of truly life-threatening diseases that could manifest first to an ophthalmologist. Moving to something a little more sinister. This was about 6 years ago when a 33-year-old gentleman presented. He was perfectly healthy and came only for refraction. His best corrected visual acuity was 6/6 N6. And our fellow who examined him in the OPD also had the presence of mind, as it is a protocol in the hospital also, to examine the fundus and referred the patient to the retina department, saying that this patient has bilateral central retinal vascular venous occlusion. This was the fundus image at presentation. Now, there are these hemorrhages scattered in all quadrants in both eyes, but what was important to note, if we magnify and zoom in, are those hemorrhages are not the run-of-the-mill dot and blot hemorrhages, but these are nothing but Roth spots. They have a pale white center within the hemorrhage. If we recall our teaching, causes of Roth spots could be infective endocarditis, systemic sepsis, leukemia, severe anemia, vasculitis, or scurvy. We obviously investigated this patient further, and we found a total leukocyte count to be 54,000 per millimeter cube. And the peripheral blood smear showed leukocytosis, myelocytes, and metamyelocytes. So this patient was referred to an internist, and they came up with the diagnosis of chronic myelogenous leukemia. And the hemato-oncologist started him on dasatinib. And the patient came to us a couple of years later, perfectly healthy, and you can see how those hemorrhages have totally disappeared. And of course, he has no visual complaints, but this is a patient we could help diagnose at an early stage of CML. This 43-year-old gentleman was supposed to undergo a corneal transplant in the right eye, and he had no other complaints in the left eye. The corneal surgeon had sent him initially for an ultrasound, and the ultrasound threw up some findings, which was 2 mass lesions, which had been measured to be about 0.5 millimeter, involving the retina in the right eye. So this is just an external photograph of the patient, and you can see the right eye has a total corneal opacity and a little bit of an esotropia, and the left eye is, the anterior segment was normal. Never miss the opportunity to look at the retina of the fellow eye. And when we did that, we saw that the left eye retina also had this translucent grayish white mass abutting the optic nerve. Just to zoom in, you can see that it's almost mingling with the optic nerve with the retinal blood vessels overlying it. At this moment, it's always useful to take a step back. And when we look at the patient more comprehensively, you can see that those lesions on the face were nothing but adenoma sebaceum, which are facial angiomas. And on asking the patient to lift up his shirt and examining his back, we can see those hypopigmented ash leaf macules, a whitish elevated patch on the back of the patient. So a true complete diagnosis would be tuberous sclerosis with bilateral retinal astrocytomas and a right eye corneal opacity. He was referred to an internist who advised him MRI and further investigations. However, the patient was lost to our follow-up. I do hope he's following up somewhere. But it's important in his case that we diagnose this condition because tuberous sclerosis has involvement of multi-organ systems being a phakomatosis. And you can see that these patients have almost a 40% chance of epilepsy and CNS tumors, as well as kidney renal cell carcinoma as well. This was a 55-year-old gentleman who presented with drop in the left eye vision since 2 days and complained of not being able to see the lower half. Now, his systemic history was significant in that he had been previously diagnosed to have chronic lymphocytic leukemia, stage 0. We'll come to the staging a little later, but CLL stage 0 essentially has, there's no treatment required at this stage as per the current guidelines guideline-based treatments. Now, this was the fundus examination showing an area of retinal opacification in the superior retinal hemifield corresponding to his inferior scotoma. And you can see the opacification along with a lot of hemorrhages along the in the peripapillary area. So this was like an arterial occlusion. Now, on the basis of this, we immediately did a paracentesis and started anti-glaucoma medication. And over a period of time, his vision did improve. But what was more important was that when we spoke to his hemato-oncologist, they decided to treat this patient because of this arterial occlusion, and he was started on rituximab and bendamustine. So this was a patient who would otherwise not have qualified for treatment of CLL, but did undergo treatment of CLL because of his ophthalmic manifestations. We've all seen, retina specialists at least have seen patients like this. This was a 28-year-old woman who presented with poor vision in the left eye since 2 days, and pardon me for the poor quality of the fundus photograph, but you can see that there's a large red retinal tumorous lesion in the mid-periphery with engorged feeder vessels, and the OCT showing a large amount of subretinal fluid and cystoid macular edema. Now, this is nothing but a retinal capillary hemangioma, and that has a strong association with von Hippel-Lindau syndrome, another of the phacomatoses, which can also have development of pheochromocytoma or renal cell carcinomas, which could be devastating and fatal. So what was interesting in this patient was we were not very sure whether a single retinal or solitary retinal capillary hemangioma really confers a risk of VHL. And on literature review, it was wonderful to find an article that answered this very question, published by Dr. Arun Singh and the Shields group, which talked about the increasing, the reducing risk of VHL as the patient's age increases. So this patient, however, did warrant further investigation, which all came out to be negative, but we did cryo to the lesion and the subretinal fluid totally resolved, and the patient actually improved to 6/6, 6 months post-cryo. So treatment of the ophthalmic condition is of course important, and that's what we do, but it was very important to note in this young lady of a childbearing age, what was her risk of having VHL and what was the subsequent risk for her future progeny. A 54-year-old gentleman came to us about 6 years ago with blurring of vision in the right eye since 2 months, and his left eye had poor vision since childhood. Now, he had been seen elsewhere twice, and he had been advised cataract surgery, and he actually came into our hospital to undergo cataract surgery. But our cataract surgeon felt that the cataract was just not good, was not enough to warrant his poor vision. He had a refractive error of +3 in the right eye, which only improved his vision to 6/18 and 8. And the left eye was definitely a high hyperope with amblyopia with a refractive error of 9.75. Now, like I said, the slit lamp only showed an early nuclear sclerosis, and the fundus examination was totally normal. So he was referred to the retina clinic with this fairly common statement that the vision is not correlating with the cataract. On a hunch, we did a perimetry. Now, the perimetry was only possible in the right eye. The vision in the left eye was too poor. And you can see a hemianopia on the right side. So this could be either a part of a bitemporal hemianopia or a right homonymous hemianopia. But all said and done, both of these conditions would warrant neuroimaging. And that's what we sent the patient for. And we could detect a large cellular mass, more than a centimeter in diameter. This was nothing but a pituitary macroadenoma producing compressive optic neuropathy. And he underwent a transsphenoidal resection rather than cataract surgery. And when he presented to us 6 months later, there was clearing of the visual field. But of course, the cataract was the same, and he didn't require cataract surgery for many, many years later. So how does one diagnose conditions that warrant further investigation or referral? Now, I think a high index of suspicion, as we all say, is very important. The reported history, especially the duration of complaints and the onset of complaints, a very rapid onset of vision loss does not really correlate with conditions like cataract or even a refractive error. And therefore, one should correlate the anterior segment findings and the posterior segment findings with the history. There's a term called diagnostic momentum. When a 65-year-old patient comes into our clinic with drop in vision, we automatically think of cataract. And if the patient is phakic, most of the times we just come to that conclusion without performing a complete examination. So as a rule, we examine all new patients, the retina of all new patients by dilation. And follow-up patients should be examined at least once in a year with dilated fundus examination. So this protocol could vary from center to center, but it's an essential part of an eye examination. And I think the days are gone where anterior segment examination versus referral for a posterior segment examination used to be the norm. How does one treat? Now, most of the conditions that I discussed are actually treated by other specialties, but the ophthalmologist is often required for regular and possibly lifelong follow-up. In many conditions which I have discussed, the ophthalmologist can help monitor disease activity and progression. For example, perimetry, which is a much cheaper and much simpler test, could obviate the need for neuroimaging in patients with pituitary adenomas, and these have been studied and published. So an ophthalmologist is always going to be involved in the lifelong follow-up of these patients. I do believe that these patients should be referred at the drop of a hat to either another ophthalmic super specialist, or in cases when one is confident of a diagnosis, to a different discipline, whether it is neurology, neurosurgery, endocrinology, hemato-oncology. So there are bridges one needs to build with other specialists and other departments. I'd conclude by saying that there is really a need for us to widen our horizons. Now, this is a typical fundus diagram that is drawn by residents and fellows, focusing only on the disc and the macula, probably because this is the view that one gets through a 90D slit lamp biomicroscopic examination. And one really has to stress to them that what you're seeing is very, very limited. You need to really look at the retina in whole But also, just to use a cliche, look at the patient as a whole, because the retinal examination is nothing but a window to the rest of the general health of the patient. So with that, I would conclude and say that we really have an important role as ophthalmologists and retina specialists to take part in the diagnosis and treatment of life-threatening disorders and make a difference in patients' care. Thank you so much.
Thank you, Dr. Venkatramani. That was great. I think that lays the foundation for a lot of discussion. I think the first issue over here is related to CRAO, which I would like to, because this is one thing which is a true emergency. And one comment I'd like to make is, see, the photographs that we normally show are those with the opacified retina, where there's a well-defined area of white retina, a cherry red spot, and there's no making a problem in the diagnosis. But this is also the stage when it's too late. Actually, the important thing is, and I think I would like you to stress that in the earliest stage, say 15 minutes after a CRAO has occurred, these features are not there. The opacification occurs a few hours later. And so if a patient comes to you with sudden vision loss, and it's in the neighborhood of counting fingers or even PL positive, the first thing to look for is there any cattle trucking? Because that is the only sign you'll get in the earliest stages. Other than that, you will get nothing much. And then if you find that, you're dealing with a CRAO. If your vision is at the level of PL positive, then chances are you're actually dealing with an ophthalmic artery occlusion, not even a CRAO. So would you like to comment on this?
I think so. You're absolutely right. It's just that we, practicalities aside, because we obviously rarely see patients in that golden window, as it's called. And a lot of studies, including those by Son Singh Here et al., have shown that the 90-minute window is quite crucial for retinal recovery. But I think you made a very valuable point that within 90 minutes, if we are able to detect or suspect a CRAO, first aid in the form of a paracentesis or a gonio massage or any other method of lowering the intraocular pressure, whatever it may be, is definitely warranted. And I think everybody should be conversant with those techniques and should be able to do them in the clinic itself. I mean, there's no real need for admission or for further tests or investigation. It's on that clinical hunch that one can initiate this first aid treatment. There are really very few ophthalmic emergencies. I mean, CRAO and chemical injuries are really true emergencies. And I think these are patients where we can really make a difference in that golden window.
Yeah, so if we miss that, the first few hours before the opacification has set in, we've actually lost a valuable opportunity, because that's when we could maybe in 40% of patients, we may have made a difference. So this is one thing which I like to stress upon for all young ophthalmologists. Please don't miss that window. Everyone talks of the cherry red spot. Cherry red spot is irrelevant, actually. The other thing is in CRAO, and I've learned this over the last year or two, hyperbaric oxygen can sometimes help. So, and that works best if it is given in the if it started in the first 24 to 48 hours. So again, hyperbaric oxygen is something that can, if you have the facility, please try to get it initiated, and sometimes you may make a difference to the outcome. The other important thing is, in a CRAO, if he comes with this opacification, you have to still, it's not the end of the thing. It's the beginning, as you said. A complete cardiac workup. He needs an echo, he needs a Doppler, he needs a carotid angiogram, all those tests to rule out any cause of an embolus. And so that's why I always tell these guys, I say, look, ye jo ho gaya, but please immediately go to your cardiologist, get the whole thing done. And then sometimes you're worried that the cardiologist may not take it so seriously. So I mentioned there that at least an echocardiography, carotid Doppler, are the very minimum. And I think now we are able to do ophthalmic artery angiographies also fairly well. So it's easier to do whether there's any blockage there. Dr. Yadav, would you like to add something to this?
Yeah, no, it was a good collection of cases what Dr. Devendra showed. So I just recollect one patient that we saw. So patient had received multiple anti-VEGF injections for subretinal fluid. So because now everybody is giving anti-VEGF injections, so whenever there is a poor response, suboptimal response, you should not blindly continue that thing. So that patient, we did FFA, there was no leakage, there was no vascular problem. So such cases, you should always suspect that there is something amiss. And this patient on testing was found to have multiple myeloma. So these things are all important. So hematological disorders, gamma globulin problems, and similarly one case we had seen came with just a floater, vitreous hemorrhage, and on dilated examination we found VHL in both the eyes, and this patient was found to have systemic associations also. So a complete ophthalmic examination is a must.
So I think one thing is clear, that you must do a dilated examination in all patients. But I'll come to another aspect. Sometimes you get a patient who says, I'm having vision problems. And you do the vision of the patient and he's got 6/6 vision. This patient cannot be sent away saying you're okay. This patient needs a perimetry. You see, a patient who gets a severe vision loss will also complain of a severe field loss, will also often complain of a vision loss. And when you do this vision, you'll say, oh no, you're 6/6, you can go. And you missed that opportunity to catch what was shown just now, some form of field defect in the form of a homonymous hemianopia or a bitemporal hemianopia. And you could miss a neurological lesion, which would be treatable. You know, every year I get at least 2-3 such patients whom you caught because of this. You may ask for a neurological, an MRI later on, but just get a field test done. Simple test, you'll get an idea whether something's going wrong. So this is the other thing which is important.
I think confrontation also is very important.
Yes, you can, that also, but sometimes, you know, confrontation, we are not so this thing, we may miss unless it's very gross. A field defect on automated fields will show anyway, there's no problem. So this is the other important thing. One last thing about, we were talking of CRO. One situation where there's actually a mayday is if the patient's coming with a CRO and he says he's having a lot of pain on the temporal side, and you feel over there and you may actually be able to feel a roll when you roll it up, you may feel the temporal artery. Now this patient is getting a giant cell arteritis. He is getting a temporal and this can be bilateral as quickly as within 24 to 48 hours. Something which is truly mayday and should not be missed. So we must be careful. If a patient comes with a CRO, this is the other thing which you want to miss out. The same thing also applies for if he comes with what looks like an AION. That again could be related to this. So both these situations, don't miss this temporal sided headache or temporal sided pain and tenderness. Don't ignore that, because tomorrow you will regret that you missed that opportunity. So this is the important thing. Is there anything else you'd like to add? Would anyone else like to add something? Any of the other panelists would like to add something?
Sir, Karthik from Madurai. Similarly, we actually suspected and found the patient with Takaisu arteritis. We went to a rheumatologist and we found Takaisu. And actually, we also found one full family of VHL actually. Almost 7 members are involved and one of them died of renal cell carcinoma. One had very high BP. He had pheochromocytoma. So as everyone told, I think it is really important to look at the fundus. It gives a lot of possibilities actually. So many processes just by examining the fundus. Thank you.
Yeah. And finally, any patient who comes with a cataract, but the cataract is not commensurate with the vision loss, the fundus examination is mandatory. And that is something that goes without saying. I think Dr. Venkatramani sir talked about it also.
Dr. Just one small comment.
Yeah.
Yeah, we recently had a case where we had a bilateral arterial occlusion, and we did the cardiac workup and the 2D echo, it turned out to be negative. But actually, when you look at the history of the patient, he comes with peripheral ischemia, he has infertility and everything. And then you had the thrombus, which was sitting at the aortoiliac junction. And that was what was causing the embolus. So this was a Lerish's syndrome, which eventually lead to multiple emboli in the both the bilateral arteries, carotid arteries, and that caused the occlusion. So most of the time we tend to look only at the heart for finding the source of the embolus, but that may not be the case every time.
Yeah, so the heart and the carotid both are important. I mean, you have to look at all the major vessels,
Yes.
which go up to the eye. So and that's what's important, because you might the next time he may present with a stroke.
Yeah.
So thank you very much. Let's Dr. Ramani, now we will go to the next talk by Dr. Chaudhary, refractory DME labeling and management. I think this is extremely important, because one hears this term, oh, this patient is refractory to treatment. Now, I think we have Dr. Chaudhary to tell us, when is it really refractory? When do you label it? And then how would you manage it? Over to you, Dr. Chaudhary.
Thank you very much, sir. Once again, good morning to everybody. Let me share my screen.
Dr. Chaudhary, can you just stop share for a minute?
First
stop share. First stop share. Just stop share.
First
stop ऊपर रेड कलर का बटन होगा. मैं एक सेकंड मैं कर देता हूँ. एक सेकंड. First open your presentation, sir.
It's already open.
हाँ, अब उसके बाद शेयर स्क्रीन करिएगा.
शेयर स्क्रीन. ठीक है. Share this.
Green button on the Zoom.
No, now it's there.
Yes, all good, sir. Just put it in presentation.
Thank you. Today I will be talking about refractory DME, its labeling and management. In our clinic, all of us have seen this picture, and this is diabetic macular edema, and this is not very difficult to diagnose and treat. But like standard treatment for DME is these days intravitreal anti-VEGF injections, and most of the time we get the response like this. In upper picture you can see a lot of edema and vision loss, and after injection you see suddenly decrease in central macular thickness and proportionate increase in the vision. But we are not always not so lucky. Sometimes we also get such kind of picture in which patient frustrate us, and patient himself is unlucky, and all our anti-VEGF treatments doesn't give any desired response. So we can define refractory DME as no visible change in central macular thickness on OCT after 3 monthly consecutive intravitreal anti-VEGF injections. Whenever there's a suboptimum response to anti-VEGF injection, so we need to find out the reason. There are certain culprits, like patient may be having poor glycemic control, and serum lipid levels may be deteriorated. Patient may be having hypertension which is not properly controlled, and even deranged kidney function tests are also responsible for such conditions. And microalbuminuria is important condition in which the DME really become recalcitrant, and anemia is such a ignored thing, and patient having anemia usually have this kind of refractory DME. There's certain anatomical culprits also, like leaky aneurysm, micro or macro, at macula or adjoining macula, and sometimes there are abundance of capillary non-perfusion area in the periphery, which keep on secreting VGF and which are responsible for increased permeability of capillaries at macula and keep on pushing the fluid at macula and frustrate us. Same way, thick and taut posterior hyaloid, which is very difficult to detect, and this is responsible for holding the fluid at the macula, and it really need to be checked for. And same way, vitreomacular traction and epiretinal membrane. As far as poor metabolic control is concerned, it can be verified with laboratory investigations. And for blood sugar, the most important and reliable marker is HbA1c, because fasting and PP blood glucose may be sometimes misleading. And HbA1c gives real control for the last 3 months. And serum cholesterol and triglyceride, if they are raised, they keep on pushing the DME and along with the hard exudates over there, and it's very difficult to treat if these things are not controlled. Same way, I've seen in patient having higher blood urea and serum creatinine level, it's very difficult to treat diabetic macular edema, and that will also keep you busy. And same way, urine albuminuria can be checked with laboratory investigation, and this is very important entity, and most often this is underdiagnosed and ignored. So for all these metabolic conditions, we need to coordinate with our physician colleague, and if possible and available, endocrinologist and nephrologist are the best person to handle these situations. Most of the patient in that age group that they are having blood pressure is also any systolic pressure more than 140 and diastolic pressure more than 90 is big culprit for producing DME and resisting our treatment, our standard treatment. So we really need to check for this, and we ourselves can treat, but it's always better to coordinate with physician, and if possible, we should refer the patient to cardiologist. Anemia is quite common in our country, but often we don't look for that. And whenever you suspect for an clinically a patient looking pale, you can check this conjunctiva also, and then you can order for laboratory investigations. Two forms of investigations are important: complete blood count to check for the hemoglobin level, and peripheral blood smear to see the type of anemia, and sometimes it also gives the clue regarding the etiology also. And any hemoglobin less than 10 gram % is not desirable. It alters the hemodynamics, and it favors the increase of DME in our patients. So whenever such situation is present, patient is having anemia, you yourself can also give iron supplements, but it's always better to coordinate with physician and if possible hematologist. And sometimes patient is going to more than one ophthalmologist, so sometimes we ignore the things happen to the patient. Like if patient may have undergone cataract surgery recently with some other ophthalmologist, and he is not telling to us, so it's always ask the patient for any recent surgery like cataract surgery, particularly if it's complicated, so it will add on to development of DME and make it refractory. Same way, glaucoma surgery, particularly trabeculectomy, can increase your DME, and even OPD procedures like YAG capsulotomy and YAG peripheral iridotomy can also increase DME. Basically, all these things give a mixture of DME and CME, and it's really difficult to treat such combinations. And in these situations, we need to add steroid in the treatment regime. It may be in any form like topical drops, local in the form of posterior subtenon or subconjunctival, or you sometimes may need systemic steroids also. And whenever you find a refractory DME, always go back and thoroughly examine your patient for inflammatory coexisting conditions like iritis, iridocyclitis, intermediate uveitis, and choroiditis, and scleritis may be anterior or posterior. You have to examine the patient thoroughly. And if vitritis is present, that will keep on increasing the DME and make our conventional treatment ineffective. Sometimes patient is on pro-inflammatory medications because patient may have glaucoma and maybe on IOP lowering drugs. So all these drugs, travoprost, bimatoprost, laetoprost, tafloprost, they are prostaglandin analogs and they are pro-inflammatory. So we need to look for that also in our patients. If none of these things are present in our patient, then what to do? So we have certain things you can try in your clinics. Sometimes they may work. Like you can increase the volume of anti-VEGF. We usually give 0.05 ml. You can increase it up to 0.07. It may work, but it rarely works actually. You can increase the frequency of anti-VEGF, usually 4 weekly. You can give it 3 weekly. You can try that also, but it again rarely works. What can work actually, it's change of anti-VEGF. Sometimes you can switch over from one anti-VEGF to other. In some percentage of cases, patient may respond. What works in more number of cases is switch over to intravitreal steroid. So when not responding to anti-VEGF, we can switch over to intravitreal steroids, and so many options are available these days. But I always use and recommend a labeled steroid, FDA approved dexamethasone. And as far as anatomical culprits are concerned, so you can see in the picture, this is epiretinal membrane, and if it is present in our patient, so it will make our conventional treatment ineffective, and hardly any anti-VEGF or any intravitreal steroid will work in this situation. Similarly, one entity is vitreomacular traction, and as you can see in fundus photograph and FA, this is hardly detectable. But on OCT, you can see this is significant vitreomacular traction, and this will not let the edema go, and this will frustrate you. And this is a clear-cut case for a VR surgery. And one forgotten thing is thickened taut posterior hyaloid. If it is present, this will again make all our efforts of intravitreal injections useless, and ultimately a patient need to be referred for VR surgery for the removal of this thickened taut posterior hyaloid. Same way, while you doing the FA, you see it in detail, and sometimes these kind of microaneurysms may present at macula very close to FAZ, and these sometimes you can see these microaneurysm on OCT also, and we really need to handle these leaky microaneurysm very tactfully. So we need to laser them, we need to kill them, but we need to take utter care to treat only laserable aneurysm. They should not be very close to FAZ and should not be present on oculomacular bundle. Same way, sometimes in FA, if you see the periphery, you can find a lot of peripheral capillary non-perfusion. This is a photograph, FFA photograph, captured by a wide-angle FFA camera, and there are a lot of CNP area in the periphery, which kept on secreting VEGF, and which keeps on increasing the permeability of capillaries at macula and make our treatment refractory. So I will summarize my presentation in these 3 slides. First is how to diagnose refractory DME. So important is you should ask leading questions from patient regarding use of any IOP lowering eye drops, particularly prostaglandin analogs. Same way, a detailed history for recent ocular surgery or procedure should be taken from the patient. And a thorough eye examination has got its own value. You should not stick only to retina and OCT and FA. You should thoroughly examine the patient right from anterior segment to posterior segment to catch the culprit. And laboratory investigations are very important to find the things and to catch the culprit, and accordingly you need to treat them. And good, if your patient is refractory, you should not hesitate to go for another good quality FFA to look for a leaky aneurysm at macula and CNP areas. Same way, good quality OCT can solve your problem, and you have to see for thickened taut posterior hyaloid, vitreomacular traction, and epiretinal membrane. And how to handle your refractory DME patient? First of all, you need to control the metabolic factors by yourself with patient consultation and with the help of your physician colleague. Your pressure should be controlled very well. Otherwise, it will make the things worse. Same way, if a patient using IOP lowering drug in the form of prostaglandin analog, you can switch over to alternate drops which are not having these side effects. And if you find any coexisting ocular inflammatory condition, must treat them accordingly with the help of steroid or non-steroidal anti-inflammatory medicines. And if you find on FA any leaky microaneurysm, you need to laser that. If you have the facility, laser it. Otherwise, refer to the clinic where these facilities are available in the city. Same way, for CNP areas, you need to do PRP. And if you have the facility available, do it. Otherwise, don't hesitate to refer the patient to a higher clinic where these facilities are available. If in some cases, as I told, you can try changing anti-VEGF, and you can also try switching over to intravitreal steroid, the labeled one particularly. And very important is when to refer a refractory DME to the clinic where the facilities are available to handle them. Like in the case of leaky macular aneurysm, you need to refer the patient for focal laser photocoagulation to kill the aneurysm. And same way, if patient is having peripheral CNP areas and these are the culprits, so you need to refer the patient for pan-retinal photocoagulation where this facility is available. And same way, if you find thick and taut posterior hyaloid membrane, posterior hyaloid, you need to refer the patient to VR surgeon where this facility and the facility is available to handle this condition. And also in the case of vitreomacular traction, you should not try too much of intravitreal injection and all that. These are clear-cut cases for VR surgery, and you should refer the patient to a place where these facilities, VR surgery facilities, available. Same way, case of epiretinal membrane will not be solved by intravitreal anti-VEGF injection alone, and they need surgery for the removal, and VR surgeon is required for this purpose. And you should also take care, and whenever your DME patient is associated with any vitreous hemorrhage, proliferative vitreoretinopathy, VR traction, or tractional RD, you should not try much in those patients and simply refer the patient to the higher center where the VR facility is available, because all of these conditions need surgical intervention. Now, your suggestions and questions are most welcome. Thank you very much.
Thank you, Dr. Chaudhary. I think you brought out the entire gamut of problems that can happen, which can cause a refractory DME. But the most important thing here is, before you label a patient as refractory, he should have got 3 intraocular injections of an anti-VEGF at monthly intervals. And if after that you find that he's not responded, that's when you would say this is refractory. In fact, this is what the Protocol U study showed, that when they took patients who were initially labeled as refractory and gave them a run-in time of 3 injections, 50% of the patients responded. So that is the kind of improvement that can happen. 50% of your patients whom you've been labeling as refractory may turn out to be just inadequately treated once you give them these regular injections. The other important thing which you mentioned, and which is especially important because nowadays people ignore it. Very often you have patients who have refractory DME because there are some leaking microaneurysms. And if these microaneurysms are more than say 500 to 750 micron from the disc, from the fovea, then these can be easily treated by a focal laser. You can give up anti-VEGF agent, let the edema go down a little bit, and then go ahead and give them a focal macular laser. Once you turn off the tap, the edema will also go off. On the other hand, you can keep on treating and you'll keep on giving injections and may not go away. Of course, it's different if these microaneurysms are very close to the foveal center, then you cannot do anything about it. But be careful. There are sometimes what you call as center involving diabetic macular edema may have its origin. The site of the leak may be far away from the foveal center and may be amenable to treatment. This is the second important message which must go to everybody. And the third important thing is that when you have a patient who's not responding well, please make sure that the systemic parameters are under control. The patient's HbA1c should be looked into. The patient's lipid profile should be looked into. Anemia, as you mentioned, should be looked into. Uncontrolled BP or episodically rising BP should be looked into. Nephropathy should be looked into. If you are seeing these things, you will most probably be able to manage over the next few months the patient's DME. Dr. Naresh, would you like to add to this?
No, I agree, sir. I think most of us agree now that at least you have to give 3 anti-VEGF injections before labeling the patient as a poor responder. Just don't say that after 1 injection there has been not much improvement and I'll switch over to another agent or steroid. Minimum 3 injections are required. And after 3 injections, I think most of us agree that you can switch either another anti-VEGF or you can go to steroids. Because if you continue giving anti-VEGFs to this group of patients, only 25 to 30% of them are going to respond. You will be just wasting anti-VEGFs on them, and switching could have been a better option. So, and as you said, the systemic parameters have to be really looked into. The vitreomacular interface has to be looked into. All these things also are important.
There's a question over here about role of vitrectomy for refractory non-fractional DME. To my mind, actually, what we have is an unpredictable response nowadays. So far as we've seen, sometimes you can have the after you remove the ILM, and if you've done the vitrectomy, sometimes the vision improvement is not much, though the edema goes away. And the other important thing is, this is a procedure which looks easy, but it can give you a negative response in some cases. Up to 20% of patients could actually lose vision rather than gain vision after the procedure. Not to be taken lightly, can be taken as a last response, especially in patients who've got a vision of less than 624 or so. I would not like to operate a relatively better vision patient for this. Any comment from any of the panelists and Dr. Yadav?
Yeah, I would like to add that you should remember that once you operate, you're going to change the pharmacokinetics of the drugs also that you may be using. So they respond on a shorter period of time. They anatomically, they will improve, but after 6 months, 1 year, the edema is going to come back.
Yeah, another question which was asked was that if intraocular steroids were given initially, then how do you define refractory DME? To my mind, actually, since Ozurdex, if you've given, Ozurdex lasts for 3 months. So now that's the equivalent of at least 2 injections. Now, if over these 3 months you found no change in the edema, in the 3rd month you could consider labeling this as not responding to the steroid, and that is a very rare thing. I have yet to see a patient who has not responded at all to steroids. So if there is some response, it's still a responder, but it's a poor responder. So this is the other important thing, and rule out the tractional effects in such a case. One question was asked about the signs of CRO in the period before the opacification occurs. Now, see, when the CRO occurs, basically what happens, the flow stops. So when the flow stops, if you look now, this you will not be able to do with an indirect ophthalmoscope. This has to be done either with a direct ophthalmoscope or with a 90D examination. You will see when you look at the column of blood in the arteries and the veins, you will see the arteries and veins. The arteries is the flow is less, but in the veins it's going back and forth. You'll see the continuous column has broken down into small segments, which we call cattle trucking, and they will be moving back and forth. They will not be, or they'll be moving very, very slowly. Once you see that, that is the first and most important sign that you've got a CRO. The other important thing is that when you press on the eyeball, you will not be able to induce pulsations in this eye. These are the 2 most important signs that you're dealing with a CRO. So if you get these 2 signs, err on the side of CRO and take all the actions that you need to take to bring down the pressure even further. A paracentesis could help, intermittent pressure release could help, give everything needed to bring down the pressure to the maximum. And then we also have a recent thing saying that maybe a vitrectomy can help in some of these patients. So if you want to consider this patient for vitrectomy, this is the time to where the best prognosis will occur. And the last thing is, of course, I remember at least 2 cases in recent times where the patient came with a fresh CRO. It gave him the option of surgery and found out, but he had a history of a recent surgery for this blocked coronary arteries, and the cardiologist refused to give permission, so we couldn't take up for surgery. So get a cardiology checkup done immediately. So this is how you can pick up an early CRO before the opacification occurs. The most important of this is the cattle trucking, the movement, the flow within the, you're being able to watch the flow of the corpuscles within the vessels. Now,
sir, if I may add,
yeah. Yeah.
Talking about the refractory DME part, I had a very small point to make. One, that we should also look at the drugs that the patient is taking. Pioglitazone was one thing which was ascribed as causing DME. We generally don't find it in prescription of urban patients, but rural patients, still you find a lot of them on pioglitazone. That can be tried. Secondly, switching over patient from sulfonylureas to gliptins. This we are looking at right now. It has helped few of our patients. We are going to come up with a larger study very soon. And gliptins do help in controlling DME. And lastly, aerobic exercises. Dr. Chaudhary had wonderfully covered all the aspects. I'll just add that aerobic exercises do bring down the thickness in few of my patients.
Thank you. I'm actually, basically, I'm going through the audience questions also so that we can also all answer them at the same time. There's one question here about why did you suspect a pituitary adenoma, and why did you get an HPF done? Now, basically, when you get a patient who comes to you and says, I'm having a vision loss, and you've done his vision is 6/6, don't think that he's a fool. There is something wrong somewhere. So the next thing when a patient complains of vision loss and his visual acuity is normal, always get a field done. Because that is the patient is not able to explain that he's not able to see clearly. He's just saying, I can't see clearly. Now you try seeing yourself, take a telescope, look through that and try to walk. You have 6/6 vision and you are blind. And that is what starts happening when the patient gets a field defect. So this is one important thing. Now, in these patients, look carefully at the optic nerve. If you find any doubt of any optic dyspallor, it's a very, very important reason for going and doing a visual field. So basically, just a patient who complains of vision defect but is found to have normal 6/6 vision still requires a field test. And the second thing is that when a patient comes to you with these complaints, also look at the optic nerve. And if the optic nerve shows any kind of pallor, it's better to go ahead and do a field test. Now, I'm going to put the next question to the House. Is there any study correlating hyperinsulinemia and diabetic retinopathy? It's by Dr. Sandeep. Any comments from any of the panel? I am not aware of. I'm not sure if anyone has any comment on this. Okay, so maybe we will look into this, and I think Dr. Yadav has a very strong research team. Maybe he can ask somebody to look into this and answer your question. I think drill will be coming soon. So I'm not answering this question right now. We will get to drill soon. The other important thing is about 3 monthly injections of anti-VEGF. How much response is considered inadequate? First thing is, any response is considered response. If you have more than a 50 micron decrease in retinal thickness, you have a partial response, and that's worth pursuing. This is a slow responder who may take 6 months more to respond, but is responding to your treatment. Then Dr. Ramesh Venkatesh to everybody. What is the role of PRP in non-proliferative diabetic retinopathy with refractory DME? Good question. Starting with Dr. Yadav, your comments, please, and any of the panelists after that.
I think before going to PRP, I would like to switch to steroid and see whether there's a response with the intravitreal steroids. If with the intravitreal steroids also there is no response, then based on the FFA, I could take a call, but you need a wide field angiograph, not the routine angiogram. And so there are conflicting reports. So earlier we were very keen, and I have done some cases and done scattered PRP, but somehow I have not been very happy with the results that I got. But this is also an option. Basically, it's sort of graded. So you switch the pharmacotherapies, whatever is there, and then you can take help of this targeted laser also.
Any comment from any of the panelists?
I have my experience with targeted retinal photocoagulation, sir. This was what we studied at RP Center also. There was a thesis of one of the candidates, and we had very promising results that the thickness does come down if you do targeted retinal photocoagulation. But as sir said rightly, you require an ultra-wide field angiograph before you consider this therapy.
Okay, so I'm going to give 2 comments on this. Number one, go to the Protocol S study. If you see the Protocol S study, now, though your question is of NPDR, but very severe NPDR, I will consider in the same category. Now you have a patient, so what did they find? They found that patients who had PDR with DME, when they were put in the group of monotherapy, the number of injections was almost double of what would happen if you gave them a PRP plus anti-VEGF agents. So the number of injections goes down tremendously if you've done a PRP in a patient who's got PDR with diabetic macular edema. And to my mind, that is one of the biggest sort of trend setters, or showing something that shows you a trend that, look, if the PRP was there, the number of injections may have gone down. Now, the important thing here is, the ischemia is not in the central retina, it's in the periphery. So a peripheral laser, I'm not even talking of targeted laser, I'm saying peripheral laser going, say, 3 disc diameter beyond the arcade. You're nowhere near the central retina. You're only picking up the ischemic areas now. Your field will not be affected, number one. Number two, the periphery is now covered. You have removed all areas of ischemia. So you will end up getting the same effect that you would get in a normal PRP with this injection. So I believe there is a role in refractory macular edema of doing a peripheral laser? And the answer to that is coming from the protocol S. So you can't have a bigger study than that. So this is the first important thing. The second thing, many of the centers, or let's say, no, very few of the centers can have the kind of facilities RP Center has, or Dr. Yadav has, but all of us have angiography cameras which are at least 50 degrees. All the cameras nowadays available have views of 50 degrees to 55 degrees. If you ask the patient to look up, down, right, left, you will be able to pick up peripheral capillary non-perfusion up to 100 to 120 degrees. And that will give you all the details you need about peripheral capillary non-perfusion. So don't fret if you don't have an ultra wide field camera. Make sure that your angiography is done properly. We've been doing this for 2 decades, actually. We've never used an ultra wide field camera, but in every angiography, you ask unless it's only for ARMD, you ask the patient to look right into the periphery and you tilt the camera on the opposite side. You will be able to see the periphery of the retina beyond the equator. And that's all you need. So you will be able to check up for capillary non-perfusion, and then you can treat the periphery accordingly. So to answer that, my personal thing is that it's worth giving if you're not getting a response.
So can I extend that question further a bit?
Yes.
So my question is that suppose you are clinically saying that your patient has got severe NPDR, and you advise an FFA. There is diabetic macular edema, center involving diabetic macular edema, and on the FFA you see CNP areas but no neovascularization.
Yes.
Would you consider at the first time itself treating the CNP areas with laser and adding the anti-VEGF together with it as well?
Yes. So okay, now the problem is the old studies people have given up on, and the subgroup analysis were missed at that time. If you go to the ETDRS study, it says in patients who have capillary non-perfusion in 4 quadrants, in all 4 quadrants, these patients are liable to develop proliferative diabetic retinopathy in more than around 60-65% of cases within a year or so. Therefore, in this situation, I have no hesitation about saying, first give the anti-VEGF agent, because the main problem is the edema. And after I've given, say, the first or the second anti-VEGF agent, I will then go ahead and do the PRP. Specifically, if I feel this patient may not come on a regular follow-up, because this anyway is indicated for PRP. Taking care of the edema first is important, but after that, initiating the laser, there is not absolutely, completely, I believe, an academic way of managing the patient.
Thank you, sir.
Can we go ahead?
Sir, lastly, regarding the previous question about the hyperinsulinemia, there is a study going on actually called a focus study.
Okay.
They are studying a drug called semaglutide. Basically, they are going to increase the insulin secretion, and they are actually studying the progression of diabetic retinopathy with semaglutide. So that is one study probably which is going on now. And as Arvind, actually, they are part of this study.
Okay. Thank you very much. At least we are able to answer our audience to some extent. We'll go ahead to the next topic. Dr. Karthik Kumar is now coming. He's going to tell us about OCT biomarkers of DME. And the person who asked us, Dr. Shikha, about drill, please hear carefully. He's going to answer your questions.
Sorry. Are my slides visible? I was muted actually. Yeah. Thank you, everyone. Thank you, AIOS, for giving this opportunity to talk about this wonderful topic. I'm Dr. Karthik Kumar from Arvind Eye Hospital, and today we are going to talk on OCT biomarkers in DME. So as we all know, diabetic retinopathy is a microvascular disease which is progressive. And
Sir, sorry to
WHO...
interrupt. Can you put it in presentation mode?
Okay. Sorry. Is it okay now?
Perfect, sir.
Yeah. So diabetes is a progressive microvascular disease, and WHO estimates that almost 366 million people will be diabetic by 2030, and almost half of them will be having diabetic retinopathy. 30% of the diabetics over 20 years will be having some form of DME. So as we all know, DME requires repetitive invasive intravitreal injections, and this is going to place a heavy burden on the patient and overall healthcare. And by now, actually, there are no reliable methods to determine which individual with DME is going to get good vision over a period of time. And so there are some unmet needs which can be answered by these biomarkers, which are basically a merged word of biological marker. This refers to some medical science that can be objectively taken into account, which indicates the state of health and well-being of an individual. They can be anatomical, biochemical, or it can be a molecular parameter. And here in DME, it can be imaging facility also. So there are various imaging biomarkers like fundus photography, autofluorescence, fluorescent angiography, OCT angio, adaptive optics. And today we'll discuss the biomarkers on OCT. And last one slide on OCT angiography. Now, why OCT? OCT is, it is non-contact, non-invasive. You don't have to pick the patient. It gives very high resolution images similar to an optical biopsy. And of course, because of all these things, you can consider this as a very good biomarker to predict the visual outcome. So these are few biomarkers which I'm going to discuss. And the first and foremost thing, everyone talks about the macular thickness. Whenever a patient comes, if the patient has DME, the first thing which comes to our mind is retinal thickness. And of course, the foveal contour is going to be lost. So when we see the OCT, what we are going to see is basically the macular thickness map. This is the ETDRS circle with 3 circles. The one in the center is the 1 mm circle. The one next is the 3 mm radius circle, and the last one is 6 mm circle. The one in the center is basically the 1 mm circle which we are interested in, and the average thickness here is called as the central subfield thickness, which we are interested in. And as all the studies says, significant increase in this macular thickness is associated with increase in the severity of diabetic retinopathy, and of course, there are going to be decrease in the visual acuity. And of course, with good treatment with either anti-VEGF or steroid, if the macular edema decreases, we always assume that the visual acuity is going to get better. And there are different types of diabetic macular edema. We have spongiform, we have cystoid form, we have serous detachment, and of course, we had a traction. We also have a tractional RD. A study of 125 eyes with treatment-naive DME reported overall worse visual acuity with the cystoid form more than the other forms. Serous detachment is seen in around 30% of the DME, more common with severe forms of diabetic retinopathy. And one study says that the presence of serous detachment at baseline is associated with a very favorable visual outcome post-treatment. And interleukin 6 levels were significantly higher in eyes with serous macular detachment than in eyes with other form of diabetic macular edema, which indicates there is an active ongoing inflammation, and many of them prefer to use steroids in these conditions. And many literature review states that diffuse macular edema gives better visual acuity than other forms of macular edema, but overall there is no consistent data to support that one form of macular edema is going to be having a poor prognostic significance than others. Talking about cystoid macular edema, visual acuity is not associated with either the presence or absence of cyst, but we have to take into account the number, location, and the size of the cyst rather than just the presence or absence of cyst. The larger cysts are definitely going to have the negative effect on the retinal sensitivity. It is basically the amount of remaining retinal or the foveal tissue which is going to tell us about the visual acuity. There are many studies again which tells that the size and location is not going to be, it is going to be of significance, but mainly the remaining tissue which is left behind is what is going to determine the visual acuity. So now taking consideration into all these things, whether the macular thickness or the central subfield thickness alone is enough to predict the visual acuity in DME. So that is the question which we all have to think. So protocol A in a DRCR-NET, where they compared the OCT measured retinal thickness and visual acuity in eyes with macular edema before and after macular laser photocoagulation. It tells us that there is only a modest correlation between BCVA and the central point thickness prior to focal laser. And of course, there is only a modest correlation between the change in visual acuity and change in the central point thickness through the first year following laser. So many eyes with thickened maculas had good visual acuities, and many eyes with normal thickness had decreased visual acuity. This is termed as paradoxical visual acuity, which is very difficult to explain. So these suggest that OCT measurement alone may not be a good surrogate marker for visual acuity, as these studies state. And there's another study, which is the protocol T, is a post-hoc analysis of the data. It says that there is at best a moderate correlation between visual acuity and change in the macular thickness after VEGF therapy, but this accounts only for a small proportion of cases actually. So for any given change in the OCT, CST from baseline, there is a broad range of changes in the visual acuity at baseline, at 12, 52, and 104 weeks. So from all these things, we understand that CST is a useful anatomic surrogate to diagnose and monitor DME, but of course, it is not an accurate predictor of BCVA. So we have to search for other biological markers also, so that we can explain the patient about the prognosis. All the all the things the patient worries is only about the visual acuity. Even though we explain that the macular thickness is small and all those things, the one thing the patient expects is vision. And so to tell the prognosis to the patient, we have to probe further actually. So one such thing is the drill, that is disorganization of the retinal inner layer. So this is nothing but this is basically the loss of boundaries between the layers of retina. It is defined as horizontal extent in microns, for which basically the boundaries between the ganglion cell, inner plexiform, inner nuclear and outer plexiform could not be identified. So to tell you, see, this is the area where we can have, or we can see the layers of retina which are quite intact. But this area, we see that there are no layers as such. So to identify drill, it is very easy actually. So what we have to do is, from outside the central macula, we have to trace these layers and come to the fovea. If you are able to come and reach the central fovea, it means there is no drill. If the segmentation zones are not present, then drill is present. So it is as simple as that. So this drill, about this drill, actually there's a paper by Dr. Jennifer Sun. This is the first paper which talks about drill as a predictor of visual acuity in eyes with central involved diabetic macular edema. These are the pictures from the paper. So what they concluded was, centrally located drill is correlated to visual acuity in eyes with central involved DME. So change in drill seems to be a robust predictive biomarker for future visual acuity outcomes. And of course, association of drill extent change with visual acuity is more consistent than any other OCT parameters evaluated for central subfield thickness change. So they concluded that if there is more than 50% of drill affecting the central 1 mm zone of the retina, that is the central subfield thickness zone, then the patient is going to have poor visual outcome. And more than 300 micron change from the baseline in the central 1 mm fovea, from baseline, that is from 4 months and to about 8 months period. So any change in the drill area is also going to be very associated with very poor visual prognosis. So drill, what is basically drill is basically the dissection of the cells in the inner retina, basically the bipolar cells, amacrine cells and horizontal cells. And the hypothesis is that there is going to be a disruption of pathways that transmit information from photoreceptors to the ganglion cells. So the key thing is we usually see drill in chronic patients, that is more than 6 months of macular edema. And these patients are going to have significant amount of metamorphopsia. And of course, when there is slight improvement in drill, the visual acuity also improves. So these are the things which we get from this paper. And next, another important thing is the hyperreflective foci. So these were described by Bose et al. And these are dots which we see commonly in the OCT in all the layers of retina, particularly the inner layers. So these are thought to be subclinical hard exudates. These are thought to be due to the breakdown of inner blood retinal barrier, which leads to lipid extravasations. Thus, these are nothing but subclinical hard exudates. These are seen in DME. Many times we do see in other conditions also, like wet AMD. So there it is thought to be something like migrating RPs or the regenerative photoreceptors. And of course, many people do consider this as activated microglia. And the presence of many hypereffective foci indicates that we are dealing with tissue disintegrity more in case of severe DMEs. And they do respond to anti-VEGF injections. If the patient has high number of hypereffective foci, we can tell the patient that the treatment is going to be slightly poorer, but the outcome is going to be slightly poor with the anti-VEGF, and we can consider steroids, because many people consider these to be some form of inflammation. So steroids do work better with patients with hyperreflective foci. And one interesting finding is that hyperreflective foci positively correlates with the HbA1 value. So if the patient is going to have high level of HbA1c, we do expect some higher amounts of hyperreflective foci in the OCT pictures. And of course, if the ELM is going to be disrupted, these hyperreflective foci do go into the outer retina. And if you find these in the choroid, it means that the patient is definitely going to have some poor visual acuity and higher form of diabetic retinopathy, like more in PDR than NPDR. So these are things about the hyperreflective foci. And another important thing is the ELM, which you all see. This is the ELM, which is shown here. This is a line which is most important. We all see the ELM in the OCT. There is a plexus between the molar cell and the photoreceptors. It is basically the third blood retinal barrier. When this is disrupted, the fluid enters the outer retina. And this ELM status is more closely related to the visual acuity in DME, and it is useful for prognostication purpose also. So here you can see in the picture that the ELM is gone, and the patient is going to have definitely some poor vision. And we all talk about the ISOS junction, which is basically the photoreceptor layer. There are various terminology like cost line, ellipsoid zone. So we just make the matter simple. We will address it as ISOS junction. So these are basically the photoreceptor layer. Any disruption of these photoreceptor layer is going to be more damaging. So this is the yellow line actually, which represents the ISOS junction. And the percentage disruption of this layer has significant predictor of visual acuity in patients with DME. So we have to assess this ISOS junction. And of course, this is going to be we can also actually grade both the ELM and the ellipsoid zone or the ISOS junction are closely related actually. So one gets disrupted, the other also has a chance of getting disruption. Usually the ELM goes before the ellipsoid zone. And finally, about the choroid, in DME, we find that the choroid is thin actually. So the mean choroid thickness is much thinner in patients with DME. And of course, if you have a thicker choroid, it's going to be, the choroid is going to have intact choriocapillaries. So lesser outer retinal ischemia, and of course, the photoreceptors are going to be preserved, so better visual acuity. So that is the concept behind this thin and thick choroid. So basically, we can see the choroid for the thickness in case of DMEs. And finally, a note on a topic called parallelism. So what they do is basically the outer retina, the subfoveal area covering the photoreceptors are skeletonized actually, and the segmentation lines are taken into account, and we see the lines whether they're parallel to each other. So when they are parallel to each other, the vision is going to be better. In DME, this parallelism is significantly lost. So this is one of the parameters which we can take into account. And a note on OCT angiography. We are very excited about OCT angiography because we don't have to inject the patient with fluorescein without doing anything, without going for a time-consuming invasive procedure. All we can do is take a OCT angiography and see for the FAZ. The foveal avascular zone in diabetic macular edema is usually irregular and is going to be large, especially the deep capillary plexus gives a good idea about the extent of diabetic macular edema. And if the deep capillary plexus is going to be good, we can say that the treatment to intravitreal injection will also be better. I mean, it's going to be good actually. And many microorganisms which are not seen on FA can also be picked up by OCT angio. And if you're going to talk about the vessel density, Of course, in case of diabetic macular edema, the parafoveal area is going to have poor vessel density right from the initial to begin with, basically. So, in the end, take home message. OCT serves a very good biological marker because it is non-invasive. Nowadays, it is available everywhere actually. And central subfield thickness, yes, it is regularly believed that it is going to be correlating very well with the visual acuity, but many times it's not going to be so. Other factors like drill, hyperactive foci, ELM continuity, integrity of the IOS junctions are also going to be very important to predict the visual acuity. Of course, you can also take into account the choroid and OCTA to see the foveal avascular zone. And thus, these OCT biomarkers can help in diagnose, grade the severity of the disease, modify our treatment regimen, and predict the prognosis in diabetic macular edema. So in the end, don't consider only only about the macular thickness. We should also go deep inside the OCT, check for other OCT biomarkers to help the patient, and also to prognosticate the disease actually. So thank you so much for giving me the opportunity. Thank you, sir.
Thank you, Karthik. Any comments, Dr. Yadav?
No, I would just like, it was a nice presentation. I think you covered all the biomarkers very nicely. This is just for the general ophthalmologist. So basically, I think most of the people have fundus photographs. So I think they should take it routinely and they should try to look at the microaneurysms also. So if you see that the microaneurysms are appearing more frequently, there's a faster turnover of the microaneurysm. So that could give you an idea that this patient is likely to develop edema. So such patients could be counseled about the systemic control and they can be followed more closely. Once edema is there, then the treatment is easy. But we are interested in looking at which patients are likely to have macular edema. The other thing could be that OCT also, sometimes there may be no edema, but the patients may have hyperreflective dots on the OCT. So this also is a sort of predictor that these patients are likely to develop macular edema. So this is just for the general ophthalmologist that I wanted to tell.
Yeah, regarding drill, because everyone talks about drill all the time nowadays. Dr. Karthik told you very clearly very nicely how to diagnose drill. So you go from, basically it's the inner layers that we're talking about. And you're looking at all the layers, whether it's the nerve fiber layer, the ganglion cell layer, the inner nuclear layer. These should be moving all the way up to the fovea and should be visible. Now, where they become homogenized, where you don't see the layers, that's the area of drill. And the bigger this area is, the more the likelihood that the visual prognosis will be affected. But there's a caveat here. If that area has a cyst, it's no longer relevant. A cyst is not the same as saying that it's homogenized. A cyst will only push the layers to the side. So on the sides of a cyst, it will look as if it's homogenized. So only when the cyst goes away will you talk about that area being a drill. Otherwise, you cannot actually comment whether this is drill or not. You may say this may be drill. And this is where this confusion comes and people say drill is reversible. It is not drill which is reversible. What is more reversible is the edema goes away and the crowding that has happened of the tissues on the sides of that large cyst, that crowding stops. So what looks to be a kind of a drill kind of picture then becomes normal. So basically the important thing is when you comment on drill, you should also see, is there a lot of large cysts around that? If there are a lot of large cysts, don't call it drill, wait for the edema to resolve, then you will be having a better idea whether this is truly speaking drill. We have one question here. Does the turbidity of the cystoid fluid have any bearing on the treatment response in DME? It's a very good question. And any of the panelists wants to make a comment? Karthik, start with you.
No idea, sir. I don't have much idea on the turbidity part of the drill, actually.
Yeah. So actually, frankly speaking, when you see this turbidity of the cystoid fluid, these cases are more resistant to treatment. And very often they will not respond well to anti-VEGF. And personal anecdotal responses that giving a steroid results in that cyst becoming smaller much better, though it may not totally disappear. It may, the size may become smaller, but may not totally disappear. But the best response seems to come with steroids. Dr. Naresh, would you?
No, I completely agree. I think with duration, most of the cysts can develop hyperreflective material, and they can become turbid. Same thing we have seen in vein occlusions also. I think with time, that shows that inflammation is playing a big part here, and such patients may respond better to steroids. Ramesh, you want to add something? Because you have done some work on this.
Yeah, so I'll be showing those cases in my slides, sir. Those cases of hyperreflective material in a DME cyst, and then say how they are responding to treatment. Just one question which I had for both of y'all is that how much importance do you pay to the peripheral hemorrhages and microaneurysms on the color fundus photograph or on the Optos image to decide whether this patient is going to have a refractory DME or a non-responsive or a delayed response macular edema?
Okay, I don't think I've looked at it from the point of view of whether it will be refractory. But the point is, if you have microaneurysms in all the quadrants, that goes into a severe NPDR. And actually, that's the kind of case where you should do a fluorescein angiography to check, do you have a lot of CNP areas in the periphery? Because you may be thinking this is just early NPDR. It's not. If you've got microaneurysms in all the quadrants, it's actually at least moderately severe NPDR.
So what I meant by peripheral microaneurysms is something which is not, which is there even anterior to the equator.
Yeah, I'm talking of peripheral only. I'm talking of at the equator and mid peripheral area. Anterior to the equator, without you can't consistently see without having a ultra wide field.
Okay. So, but do you think that the hemorrhages or the microaneurysms, when they are more extensive, though you may grade them as severe NPDR, do they contribute to the non-responsiveness to an anti-VEGF? Because my understanding is that the more number of hemorrhages you have, the body will, it is a vascular insult. So when the hemorrhage happens, there has to be an inflammatory response which needs to happen to that blood which comes onto the retinal surface. So when there is an inflammatory response, so probably, so the more number of hemorrhage, more the inflammatory response. And that is why probably these macular edemas don't respond just to plain anti-VEGFs. Probably you may have to treat them with steroids as well.
Yeah. So it's a little more complicated, no? Because it's the hemorrhages occurred because of the ischemia in the first place. Yes. Because of the blockage of the capillaries at the capillary level. And those hemorrhages will incite an inflammatory response too. Yes. So it's a vicious cycle. Now, if you did, that's why I said, if you do a fluorescein angiography, chances are in the periphery you would find extensive CNP areas. Now, the CNP areas would contribute to more and more VEGF, which means the chance of your ending up with a refractory edema is higher. So all the things would contribute together, but we need to do a study. This is building a hypothesis, but we need to do a study actually to make that correlation and do the correlation with the CNP areas and then do the correlation with the treatment of those areas, so which I think you mentioned about.
I actually was trying to look at this aspect. Means when you have a patient with severe NPDR and you have a DME, you do an FFA. If the FFA does not show CNP areas, and then treat the patient directly with an intraocular steroid.
Yeah.
But if the patient has CNP areas, treat the patient with anti-VEGF. Probably in those cases, your response to the treatment will be ideal because you're trying to hit the mechanism in the right way. Because there you believe that if you have severe NPDR, 4-quadrant hemorrhages, those hemorrhages.
I lost you.
Yeah, not able to hear you.
Can you hear me?
Yeah, now I can hear you. Yeah.
Hello.
Yeah. So
those hemorrhages are leading to an inflammatory insult, and that is what is causing the macular edema there. So in the absence of CNP, treat with steroids. In the presence, you treat with anti-VEGF.
I'll give a little caveat here. First of all, it's a misnomer to say that anti-VEGFs don't have an anti-inflammatory effect. So the anti-inflammatory effect comes from anti-VEGFs also. So my first line treatment is always anti-VEGFs. And if I don't get, and the reason is very simple, be safe before you are effective. And safety-wise, you're safer with an anti-VEGF than with a steroid. So if the anti-VEGF doesn't work, you can always shift to steroid. Don't start off with steroid because you're not getting anything great as an advantage. You're getting this thing. In a few patients, you may get an added advantage with steroids. So it doesn't make sense to go for a less safe drug first. And let's be very, very clear, anti-VEGF is a safer drug as a group than steroids. Okay. So I think I'm going to, is that the next lecture is also related. Dr. Ramesh is going to talk to us about what not to miss in NOCT. And since it's related, let's go through this also, and then we can have some more discussion. Dr. Ramesh, are you? And I've just realized we need to finish by 1. So we may cut down discussion a little bit after this.
So can I take my talk a bit later because I have some problem with the internet?
All right. So can we come to the next talk with Dr. Pradeep? Dr. Pradeep Kumar, examining the fundus in young.
We can start, and I'll just request Dr. Ramesh to stop sharing the screen, then I can come on.
Okay. Yeah.
Yeah. I hope my slides are visible now, sir. I'm Colonel Pradeep Kumar, and
I can't see your slides yet.
Your slides are not visible, sir.
Just a second, please. I also seem to be having some problems with starting. Are they visible now, sir?
Yeah, go ahead.
Yeah. Good. Very good afternoon to everyone. I'm Colonel Pradeep. I am presently posted at Army Hospital, Ara. That was my previous resume. What I'm going to talk about today is that why we should be examining young patients' fundus more thoroughly and what is special about these patients. Mostly they are in a hurry. They don't want to wait in our OPDs. They generally have excuses why not to dilate their eyes. They'll tell us that they are unaccompanied. They have to drive back home. They promise second visits, never come back. And the biggest problem is that they have a belief of infallibility. Still, most of these suffer from preventable visual loss, and it is our responsibility to look at their fundus more keenly. And what I am here to talk about today are a few examples where diagnoses were missed because the fundus was not evaluated, the correct methodology to ensure that a retinal diagnosis is always achieved, easy ways of examining the fundus, and few take-home messages. So my target audience today are my non-retinologist colleagues, my postgraduate trainees. The content may seem basic, but it is essential for a complete evaluation. So first, coming to the tale of few specs in vitreous. Now, most of us, when we start examining the eye, and especially on the slit lamp, the moment we start with 90D, we try to focus on the retina. We forget that there is a huge space between the lens and the retina where the vitreous is lying, which is an important indicator of a person's health. So this 35-year-old male presented with floater with a best corrected visual acuity of 6.6 in both the eyes. And this is all that could be seen. If you see carefully, there are few yellow specks which are anterior to the retina. Out here, you can see them, and they were seen more keenly on a FA. Now, this patient, initial workup for uveitis showed a small nodules in the left upper lobe. They were the follow-up of 6 months. These specs, we tried treating them with systemic steroids. They'll reduce in size whenever the steroids are stopped. They'll increase in size. And that is when we re-evaluated this patient and came with this report on PET-CT scan. The PET-CT told us that this was probably a case of CA. The CT-guided biopsy told us that it was a non-small cell lung carcinoma. And surprisingly, the vitrectomy sample also gave the same report. The resection has been done, the patient is healthy, but simply because that we were able to look at this vitreous early on. So my advice that all of us, when we are examining our patient, should also learn to examine the vitreous before we focus on the retina. Now, the second case was of a 23-year-old lady where she was just not happy with the spectacles that she was getting, multiple change of spectacles. She had a best corrected visual acuity of 6.9 in the right eye, and everybody kept changing her spectacles. And this is what she had. So these young patients, they generally have inflammatory diseases. A very clear-cut diagnosis turned out to be toxoplasma positive, responded to intravitreal clindamycin and Ozurdex, and has a stable vision. The tales don't stop here. So we had a fluctuating vision in a 31-year-old entrepreneur, 3-week history of episode of blurred vision, and everybody told that how much time are you working on your computer? He said 10 to 12 hours, and people kept treating him for computer vision syndrome, tear substitutes, and this was an easy clinching diagnosis had anyone looked at the fundus. Now, interestingly, when we started managing him and we referred him to our psychologist, we realized that this patient also had anxiety episodes, depression, and even suicidal ideation. He has received psychiatric help. We don't know whether we prevented a suicide or not, but it is important for us to help out these patients by looking at them holistically. Now, this was a 22-year-old lady, an aspiring pilot. But when she went for the medical examination, she was rejected, saying that she is colorblind. She is color perception 3 on our Ishihara chart. And she presented for reevaluation, saying that what is to be done. She was told that nothing more is required. But remember, this was a lady, and she had a color perception defect. When we looked closer, we realized that this person was suffering from a cone dystrophy, and there was a definite role of giving genetic counseling because she had a great reproductive career ahead of her. She had to choose when to have children, whom to have children with. The role of ultraviolet protection was there, which could have prevented worsening of this disease. And more importantly, we had to inform the patient that this was a progressive disease and not just a stationary color blindness. So this is important to look at these patients also. There was a 27-year-old national level marathoner. He completed his marathon and said there is heaviness in the right eye. And as it happens, he was told that it is because of excessive sunlight exposure, and he carried on for about a couple of weeks before he presented to us in this particular manner. Now, there was a case of a CRVO in young, which has a huge battery of investigations which needs to be completed before the patient can be disposed of. And after all the investigations, we decided that dehydration was the probable cause. He was advised that next time when he is doing his marathons, he should be more careful about his hydration. Though we treated the patient conservatively, we did not do any intervention. But one should remember this was too dramatic a disease to miss, and it's a potential lawsuit for the primary ophthalmologist. So even if, as has been said earlier, the vision is 6.6 or 6.9, please don't forget to look at the fundus. Now, there was a photophobic driver. He had developed photophobia in right eye, was being managed as anterior uveitis with topical steroids, and surprisingly, cycloplegics. His pupil was dilated to about 5 to 6 mm, but nobody looked at the fundus. And after about 3 to 4 months of treatment, he comes to us. This boy has got classical disc involvement. There is an evidence of retinal vasculitis. And this is an obliterative kind of vasculitis. And on focus history, he gave history of urethritis, was diagnosed as a case of Behçet. Usually these young people on their first interview do not talk about urethritis. And he was evaluated and also found to have an associated subclavian vein thrombosis. So the importance of systemic diagnosis being clinched by looking at the fundus alone comes here. And there was a swimmer, 16-year-old lady. Again, she had a healed uveitis, best corrected visual acuity of 660. This patient had developed an inflammatory CNVM. Everybody kept treating her for uveitis. Nobody looked at her posterior pole for almost 6 months. By the time we started the treatment, treated her, the final visual acuity which was recovered was 3/60. Perhaps had we intervened earlier, we could have saved much more vision. And lastly, we had a 36-year-old lady. The case of headache was already diagnosed as a case of amblyopia a few years back. And now in times of COVID, when she talks about anosmia, nobody wanted to see her. She came to our COVID facility, and this is what we saw. This is something that we had read in books, so I thought it would be very interesting to present here. This was a case of Foster-Kennedy syndrome in which we saw anosmia. Anosmia, I had already read. This is the first time I saw it in a case of Foster-Kennedy. And she had a classical olfactory groove meningioma. She has been operated. Her vision, at least in the left eye and the field, has been salvaged. So even in COVID times, it's important to look at the fundus, though one may not use the direct ophthalmoscope, but slit lamp biomicroscopy and indirect, there are very effective and safe ways of examining these patients. So what can we do to reduce these cafes, as we call it? First and foremost, as has been said by other speakers also, there are 4 components of vision. Acuity is just one part. Contrast, color, and field are important. And if we don't want to miss retinal diagnosis, we have to learn to assess them also. And color vision should be incorporated as a matter of practice. Next is swinging flashlight test. That we were talking about the assessment of CRAO. In a case of CRAO, very early in the disease, you can pick up a RAPD. So if you have a RAPD, one should start thinking in terms of more sinister diagnosis. And also, while you test the patient with a swinging flashlight test, it helps by inducing photostress. And if in the affected eye, the recovery of vision is slower compared to the other eye, one should start thinking in terms of macular dysfunction. And then one has to learn to practice non-mediatic fundoscopy. And it is not only the 90D lens, there are other lenses much more comfortable than that, which are available now. And one has to use the slit lamp to its fullest extent by using the red-free and polarized light while looking through the small pupil. And the ultimate panacea is dilate both eyes and have a look at fundus if your patient allows. So there was a small study which we carried out, presented at APVRS, and just to cut short in the time, this is what we were doing. We allowed patients to examine in conventional way with 90 diopter and 20 diopter lens, and then switch over to the newer generation of digital lenses, pan-retinal lenses, and wide field lenses. And in the other half, we were doing the opposite. What we realized as results were that whenever the patient was using, our examiners were using conventional methods of ophthalmoscopy, they were missing fundus details, which were more easily picked up by using the new generation lenses. And why was it happening? I'll just show the images. On the left-hand side, you see a 90 diopter lens being used, 16x zoom. The moment you switch to 40x zoom, this is the kind of image it appears. It's not very clear. But when you use it with a digital lens, you see the difference. This is the difference between 90D and the digital lenses which are now available. There is some difference in their optics. And if this facility is available, most of us are in a position to use these kind of lenses. So how to diagnose? Make a complete assessment of vision. Don't stop at acuity alone. Use contrast, color, and field. Tell your optometrist to check them. Always look at the pupil. The glow of the fundus is again an important predictor. This is for all my non-retinologist colleagues. The glow of the fundus should always be looked for. And if there is anything abnormal, please dilate your patient. And go beyond the standard 90D lens. This is something that I wanted to tell, that everybody should be conversant with looking for a RAPD. This is just I wanted to show for my PG colleagues, and try using this framework, that whenever you have to decide how I want to treat this patient, that are you equipped to treat? If you don't have access to an OCT, don't try to treat a DME standalone facility. If you don't have laser facilities, don't try to treat a PDR case. Try to refer them off. And you must address non-ophthalmological issues. When you have vascular occlusions, please involve a physician because they may be life-threatening. If you have CSCR, try a psychological counselor, and there are many more examples. And always have both short-term and long-term goals. For example, if you're treating a CMVM, anti-VEGF is not the only place where you should stop. Talk about engineering modification in the patient's house, low visual aids, so that you can have a long-term goal also. And don't try to treat something like this. This is one example where the primary ophthalmologist has tried to hold on to the patient for about 20-25 days before the patient came to us. And to refer these patients, you can do that to validate the diagnosis, bring the patient back to your practice, and you are welcome to treat them. For therapeutic purpose, for example, if you have a submacular bleed, yes, you will need a retina specialist for a non-resolving vitreous hemorrhage. The indications are given in book. But more importantly, don't forget the legal aspects of referral. In a case of ROP or post-surgical complication, please refer these patients. So in a case like this, definitely it will be wiser to refer. And lastly, a few humble suggestions from my side, as has been reiterated: high index of suspicion, try a dilated eye evaluation in most of the cases, augment your diagnostic array with newer biomicroscopy lenses, and experiment with various slit lamp illuminations. Thank you so much. This is my email for contact.
You are muted, sir.
Yeah.
Yeah, hi.
Sure.
Thank you, Dr. Pradeep. I think basically you put everything that people have told, the piecemeal points, into one comprehensive whole. So it was a good thing. The only thing is you've spoken a little before the last speaker, but thank you very much. I think all these points are very valid. One thing I want to know, which is the digital lens that you advise for using for the slit lamp biomicroscopy?
So I'm using a digital HiMac and a digital Whitefield. Both of them are from Vogue. I don't have any financial interest with Vogue. The ocular lenses are equally good.
So digital HiMac and digital
Whitefield, sir.
Whitefield. So you showed very well and very sort of comprehensively that there's a huge difference in what you see. So I was impressed. I thought, let me note it down and maybe try to implement it in my own practice. Can we come to the last talk first, and then we can, for 5-10 minutes, have a discussion, because actually we are running out of time now. I never thought we could run out of time, but we have. So can we come to Dr. Ramesh Venkatesh? What not to miss on OCT? Are you ready now? Dr. Ramesh? Are you there, Dr. Ramesh?
I think he's just logged off, sir.
He's logged off?
Yes.
I just talk to him, sir.
He's joined.
In the meantime, if anyone has any questions.
Yeah, log in.
Sir, Karthik from Madurai. Talking about drill, do we have any treatment for drill as such actually? I mean, do you treat drill, if you see drill? You're going to put anti-VEGF or something like that, or you're just going to...
No, you just continue with the anti-VEGF. Basically, if it was a pseudo this thing, it will start becoming better as the cysts become less. But if it is truly speaking, if it has homogenized and that area is destroyed, then the chances are less that it will recover.
Even though there is no macular edema, can we?
Even though, because actually it lost its architecture.
Yes.
And actually what happens is, even if it's lost its architecture, you see the surrounding cells can cover up to a certain area, but they cannot cover if that area becomes large. Then it's like a scotoma over there. So if it's small, it'll still not make a difference to the final outcome. But if it's large, then it'll leave a scotoma in that area, and then the visual function would be affected.
Thank you so much.
Is he coming?
In your opinion, whether the cystoid macular edema is more likely to cause drill, or is there any study that shows which type of edema is likely to cause drill?
I don't think cystoid macular edema per se is likely to cause drill, unless it's a very, very long-standing effect. If it's anything which, see, if you press some area for a short period, nothing going to happen. But you press it for a very, very long period, automatically that architecture will get deranged. So it depends actually on the duration of the cyst and the size of the cyst. So that's why I think one picture was shown also where the large cyst with a little bit of some hyperreflective material within it, that stays for a long time. Then when it goes, you'll still have drill in that entire area, because that would have that material would have actually the cells would have died, and the architecture would have been destroyed permanently. So it all depends possibly on the duration of this thing. So if it goes away, it will not cause. Even if it's recurrent, it won't cause a problem. But the problem will come if it's persistent, doesn't go away, and is large enough to cause pressure effects.
Sir, in cases of DME, I've seen many cases, the hard exudate plaque that's sitting right at the fovea, center of the fovea, the fluid goes off, but this plaque persists there, and patient vision doesn't improve at all. So what can be done for these cases?
Yeah, so the thing is, if you have a hard exudate and it's not caused fibrosis yet, then this can still go away. Okay. The important thing is that if this the hard exudate per se is not what you're treating, but if it's got edema surrounding it, When that edema goes away, your visual function will improve to some extent. And I had a discussion. We had a presentation in which Dr. Dipinder Singh was there. And he was talking about how he noted that sometimes if you continued to give treatment with anti-VEGF agents, the hard exudate went off over the next few months and some improvement in vision occurs. Now, this improvement may be because of the surrounding edema going away, and that you are not going to treat the hard exudate if there's no edema at all. But if there is surrounding edema and you continue to treat it, it will have a dual effect. The edema goes away, the para-lesional vision will become better, and over a period of time, this hard exudate goes away, and you may get some better return in visual function. If, however, fibrosis has occurred there, then the fibrosis does not go away. Only the edema part can go away, and so there will be some loss of vision in those cases.
Thank you.
Are we getting Dr. Ramesh back, or?
He just said, I think 1 minute he wants.
Okay. So any other, there was, okay, somebody was talking about how much is adequate response. So to my mind, if I am able to get, if not in every injection, if in an alternate injection, when I get at least 10% decrease in the thickness, or morphologically, see, the thickness may not be changing too much on the OCT, but the morphological change occurs and the cyst becomes smaller over the area. The subretinal fluid starts going down. I would consider that as an adequate response. Adequate for persisting on that treatment. Not an indication for making a change in the drug or the type of treatment. Anyone would like to comment on that?
So even I'm also following the criteria of 10%, sir.
Okay.
This is just the OCT morphology.
Yes, or morphology. I mean, it's 10% or even a change in morphology resulting in a decrease in the subretinal fluid or a decrease in the intraretinal cyst. It means you're just getting a response. It's enough to continue on the same.
No, I just want to have your opinion whether we have reached that stage that looking at the OCT morphology, can we decide which injection to give? Can we personalize it?
I don't think so.
We need some more data.
I don't think so. I think, and that is why I was making that point about starting off with anti-VEGF. So the decision is not based on the morphology, it's based on safest first. And safest is the anti-VEGF. Start with the anti-VEGF, don't get a response. For a breakthrough, you could give a steroid. And then when you again need to go, I would not repeat the steroid more than once in 6 months as a rule. So in the interim period, because you can very often get a rebound with the steroid. So I will follow up monthly. And if after the 3rd month, in the 4th month, I find any increase occurring, I would immediately give an anti-VEGF. Next 2 months, I would cover up.
I'll present it another way. If we have an equally safe intravitreal steroid, then how will you approach?
Okay, so if I have an equally safe intravitreal steroid, I may prefer in very severe edemas to start off with a steroid, and then go ahead to.
What is severe edema?
Maybe say if it's more than say around 750 to 800 microns of thickness, and especially if it's with large cysts. Subretinal fluid will go off with everything, but if it's large cysts, I may prefer to start off with a steroid and then go ahead to.
Yeah, because large cysts are mainly because of the Muller cell apoptosis and dying off. I think.
Yes, so we want to
more inflammation.
Yes.
So one thing I wanted to ask, what is the opinion of the house about combined injections when we are giving an Ozurdex along with any of the intravitreals? What is your opinion on that?
Frankly speaking, there was some discussion yesterday. There was a meeting yesterday also. And there's actually a study which showed no added advantage. But to my mind, it's only good for the doctor, not for the patient. And not not good for the doctor in a government setup.
Yes,
Already.
So I believe sequential is the way to go. Combined does not give you, this is not a synergistic picture. You do not get any synergistic effects. You end up spending more patients' money, and you don't give him anything more than you would get with an sequential. You could give it the next month,
Yes, sir.
You don't lose anything. Tell me, what do you get from giving a steroid and an anti-VEGF? When the steroid is going to last 3 months, if you feel you didn't get enough of a response at the end of the first month, you could have added at that time. And if you've got your response, why do you need to add? Why do you want to make the patient waste money?
I think he's ready, sir. Should we?
Okay, yeah, please go ahead. Yeah. Ramesh, please go ahead.
I am extremely sorry and apologetic for this.
No, you should just go ahead.
So I just thank the organizers, AIOS and Allergan, for giving me this opportunity. It's indeed great to present in front of my teachers and seniors here. So my topic for the day is what not to miss in an OCT. And the intent of presenting this talk is not just to show the classical features of a retinal disease on OCT, but to show some characteristic features on OCT of few not so commonly seen retinal disorders, identify the OCT findings which can affect the visual acuity, and differentiate an OCT from similar looking retinal diseases. So as we've already discussed over the previous 4 talks, that the common features on the OCT for a diabetic macular edema, a non-tractional variety, is the presence of a cystoid macular edema, neurosensory detachment, and spongiform thickening. And the other OCT biomarkers which have been commonly discussed is the DRIL, the hyperreflective foci in the retina and choroid, the ELM and the ISOL layer. So basically, DRIL is disorganization of, there is basically a structural damage to the retinal inner layers and there is loss of parallelism. The outer retina is intact and it occurs mainly due to a damage to the superficial and the deep vascular plexus. So basically, there is a vascular insult to the inner retina, and the presence of a DRIL indicates a poor prognosis. Now let's look at this OCT scan, where on the left side of to the fovea, you can see that the layers are parallel and they are intact, whereas on the and also of the outer deep capillary plexus, you can very clearly see the capillary dropouts and the flow void areas which are seen on the OCT angiography. So what I wanted to say with this slide was that if you are suspecting macular ischemia in a patient with a diabetic macular edema, you don't always need to do an OCT angiography to ascertain whether the patient is having macular ischemia or not on the OCT angiography. Probably the identification of a DRIL and a disorganization is a good enough sign to say that there is a macular ischemia which is associated with it. The hyperreflective material in retinal and choroidal vascular diseases, we have spoken about subretinal hyperreflective material in AMD cases, but let's talk about them in DME. So this is a 57-year-old male who is a non-insulin dependent diabetic mellitus patient, visual acuity of 6/6, and he has got already got 4 intravitreal injections of ranibizumab, and he develops an intraretinal or intracystic hyperreflective material. And what you can see is that post-treatment, so basically he's not been responding to the anti-VEGF, and post-injection Ozurdex, he has shown a slight response, but there is a presence of a hyperreflective material which is present within the cyst. And this is quite a rare condition. Even in this second case, we can see that this patient has had a very poor response with intravitreal anti-VEGFs, and he develops this intraretinal hyperreflective material. And post-treatment with IVTA, you can see that there is a reduction in the size of the cyst as well as in the hyperreflective material. This kind of hyperreflective material which we found in the intraretinal layers can also be found in the subretinal layers within the subretinal fluid as well. And we published a recent paper where we described the intraretinal hyperreflective material in center involving diabetic macular edema as one of the poor prognosticating signs in diabetic retinopathy or DME. So the reason why we get this hyperreflective material within the cyst is basically because of 3 reasons. You have this microaneurysm which are closely associated with the cyst. So there is a persistent leak from these microaneurysms into the cystoid space, which continuously keeps on leaking. These hyperreflective material are usually associated with discontinuity of the ELM and the ISOS. So there is a communication for the shredded photoreceptors to get collected within the inner retinal layers. So that is another theory which we are trying to put it up. And third is that this hyperreflective material is an accumulation of heme, fibrin, and hexudates. and therefore it's a mixture of hemorrhage within the cyst which is happening. So that is why it's a very poor prognosticating sign, and the poor prognosis could also be because of the discontinuity within the ELM and the ISOS layer which we have in such cases. So when we try to differentiate this hyperreflective material within the intraretinal space and the subretinal space, in intraretinal space, you get it in chronic cases of DME, where the inflammatory fibrin-like material is associated with heme. They usually respond poorly to anti-VEGF injections, and intraocular steroids are useful in such cases. Whereas when you get a subretinal hyperreflective material, they're usually associated with systemic diseases like hypertension and renal disease. They are seen in neurosensory detachment, and they usually a good systemic control of the nephrorenal problem and the hypertension helps in reduction of this hyperreflective material. And the visual acuity depends on whether the hyperreflective material is located underneath the fovea or not. So we also found this hyperreflective material in patients with acute BRVOs, where it is again a mixture of heme, exudates, and fibrin, and it is the location of the fovea at the fovea which decides what is going to happen to the final visual acuity. So this is a patient with an acute supratemporal BRVO, and what we found is that there was a presence of subretinal hyperreflective material in addition to the subretinal fluid. And when we treated this patient with anti-VEGF, the visual acuity did not improve much because of the presence of the residual hyperreflective material which got accumulated underneath the fovea. So we published this paper as well, where we said that there is this hyperreflective material which you get in vascular diseases involving the retina, such as in treatment-naive BRVOs as well. And that also indicates a poor prognosticating factor if it is associated underneath the fovea. So we all know STREM has been classically described as type 1 or type 2 when it is above or below the RP. And presence of a STREM indirectly indicates the activity of the membrane. So treatment has to be given when there is STREM. Now let's look at other vascular disorders like MACTEL. So you have an ample number of features which you see in MACTEL and proliferative and in PFTs. So this ranges right from foveal thinning to inner retinal opacification, perifoveal hyperreflectivity of the deep capillary plexus, retinal crystals, degenerative cysts in the outer and the inner retina. There's one presence of pigment plaques, SRNBM, and the retinocoroidal or the retinal features on the OCT in cases of MACTEL type 2. And these are the cases which you see in the outer retina in patients with MACTEL type 2. And what is important is that when a patient develops this outward turning of this inner retinal layers towards the outer retina, that indicates that he is probably going into the proliferative stage of the disease. So we need to look at this more carefully. But there are some times when you look only at the hyperreflectivity within the middle retinal layers, and you may actually diagnose cases of MACTEL as PAM. And this is something which I did during my initial years. And so I just wanted to put up this case where you had this hyperreflectivity on either side of the fovea, which you could see even in MACTEL, and you have this hyperreflectivity on either side of the fovea, even in a case of paracentral acute middle maculopathy. So there is a way how to differentiate between the two. So in MACTEL, you will have the other associated signs like the ILM drape and the hyperreflective spaces. But what's important is that this hyperreflectivity in the middle retinal layers is not associated with underlying shadowing, which you see in a case of PAM. So usually you will have a shadowing which will be present in a case of PAM, but not in a patient with MACTEL. And then you can have this additive imaging techniques like a confocal blue reflectance, which will clearly tell you whether it's a PAM or a MACTEL. Let's look at what is the role of OCT in vascular occlusions. So basically it tells us the level of occlusions, and it differentiates between the different types of vascular occlusions. It also tells us the severity of vascular occlusions. So let me just show you how it tells about the level of vascular occlusions. So in a CRAO, you will have a total inner retinal opacification. In a BRAO, only one quadrant of inner retinal opacification. Cotton wool spots are basically nerve fiber layer ischemic infarcts. PAM is when there is opacification or occlusion which is happening above the outer plexiform layer, and type 2 AMN when it is happening below the outer plexiform layer. So these are the various varieties of vascular occlusions which you can have. But this is very interesting This is a patient of who complained of sudden decrease in vision, and he came to us within 1 hour of the complaint, and we did AC parasynthesis. So this is how the OCT was looking, where you were actually seeing the retinal opacification. You were seeing the retinal layers actually. You can see the parallelism within the layers, and there is not significant retinal thickening. So we initially felt that this is a patient who's going to do very well with just by doing a simple AC parasynthesis and gonio massage. But unfortunately, the next day we called him and did the OCT, and you could see that the retinal thickening, the opacification, and the parallelism all were deteriorating, and we knew now that the patient is progressing. So this is on day 3, where you can see what we you can see that there is a slight ILM detachment which is developing with the inner retinal opacification. The day 7, there is a full-blown ILM detachment. And at day 10, you have already seen that this patient has developed cystoid macular edema with a neurosensory detachment, and is worsening. So what we wanted to show with this case is that what are the sequential changes which can happen in a patient with CRAO when you do an OCT at regular intervals. With resolution of CRAO, what we have seen is that when there is a resolution of the retinal opacification, it is the superficial retina which resolves first, and then only the middle retina or the middle part of the inner retina which starts resolving. And finally, you will have a total thinning of the inner retinal layers in a patient with a chronic CRAO. Blunt trauma, I just wanted to come up with these 2 important and interesting findings which we see in patients with Berlin's edema or commercial retina in blunt trauma. So this is in the A image and the OCT corresponding top OCT. You can see that there is obliteration of the optical space in the outer retina or between the RP and the photoreceptor layer. That is what we exactly see in a patient with acute blunt trauma. But as the opacification resolves, you can see that there is some irregularity which happens in the RP layer, and following which you can see these conical caps which are found, and that is what we described as the hyporeflective microelevations in the RP and the photoreceptor layer. We probably gave this term what is known as the cone outer segment cyst as well. Another interesting finding which we found in cases of blunt trauma is bacillary layer detachment. This is a terminology which I recently came across, and it is basically the improvement in the OCT technology which allows us to visualize the split in the myoid inner layer and the ellipsoid outer layer. This term was described way back in by Polyak in 1947, and it is basically a separation between the myoid and the ellipsoid components of the photoreceptor inner segment. So this is a patient with blunt trauma. He had a history of injury with a ball, and what you can see is, you can see with the white arrow, you can see that there is a split which happens between the ellipsoid layer and the myoid layer, and there is an accumulation of the hemorrhage between those 2 layers. So what this is not a subretinal hemorrhage which we commonly see and commonly describe on the OCT. This is what we described as the intrabacillary layer hemorrhage. And this intrabacillary layer hemorrhage, they usually happen because of the shearing force of the trauma, the mechanical presence of heme. There is a poor perfusion of the photoreceptors due to the stress and the separation of the photoreceptor layer, and also because of the post-traumatic inflammation. The bacillary layer detachment in patients with trauma is a very rare finding. And attachments, they usually with time they resolve on their own, and the hemorrhages they resolve, leading to an attachment of the bacillary layer. The intrabacillary layer hemorrhage undergoes resolution without showing features of dehemoglobinization, unlike the subretinal blood. So what we found is that the subretinal blood usually undergoes changes in the color, whereas the intrabacillary hemorrhage, it does not undergo changes in color, it just undergoes a spontaneous absorption. What happens with a myopic retinopathy? We describe this term known as myopic retinopathy, where there is actually foveal flattening, persistence of the inner retinal layers, there is a normal outer retina, and there is thinning of the photoreceptor layer. So this is what we described as the earliest change in cases with pathological myopia. And in addition, you can see some rare OCT findings like intrachoroidal cavitations, presence of a myopic sinkhole. So all these features are very, if you try to look for it, you'll start getting them in patients with tilted disc and pathological myopias. Posterior microphthalmos, a very interesting finding which we found in posterior microphthalmos was the presence of the retinal papillomacular fold. people have described it commonly, but what we realize is that the fold is not present in all the meridians of the scan. It is present only in a specific meridian of the scan, thereby suggesting that the shortening of the highball happens only in one meridian. There is thickening of the inner retinal layers, the outer retinal layers are intact, and in nanophthalmos, where there is a uniform shortening of the globe, there is no retinal papillomacular fold. So that is something which we found. Torpedomaculopathy, again on the OCT, is being described into 3 types. One with no subretinal cleft, the second with a cleft with inner choroidal thinning, and the presence of a choroidal cavitation and a CNVM. So this is one of our cases of torpedo lesions where we found a patient to have a focal choroidal excavation with the presence of a CNVM along with it. Hematocrit sign has been commonly described in patients with, they have been commonly described in patients with PCVs, but we described hematocrit sign in a patient with PAVAC. And this is something which you can see in the yellow arrow, which is present, where you can see that there is a layering of the RBCs and a clear fluid within the cyst. So this is something which we found in patients with PAVAC as well. In fact, it can happen with any microaneurysm or any aneurysm which are present in the renal or the choroidal vasculature. Again, en face OCT in lymphomas, you could see these white dots, which you can see in the deep layers, which are basically suggestive of the white vertical hyperreflective foci, which you see in patients with intraocular lymphomas. And following treatment with intravitreal methotrexate or rituximab, there is a disappearance of these spots. Contact sign is basically because of a granuloma, which is compressing against the RP, as a result of which there is exudate accumulation which happens and a neurosensory detachment. And following treatment with corticosteroids or with antitubercular therapy, you can have the reduction in the choroidal granuloma and the contact sign. Again, choroidal nevus, a very useful tool where you can see the shadowing which happens behind the nevus in the choroid. And also very useful to identify the presence of a CNVM in a patient with choroidal nevus, where the OCT angiography also helps us to identify the neovascular network. So this is a paper where we describe the findings of choroidal imaging findings in choroidal nevus with color fundus photography. So basically, to summarize, in all, the OCT is an extremely important imaging tool in retinal practice. The diagnosis, treatment, and monitoring of a particular retinal disease is based on the OCT, and it's very important to understand and analyze the OCT properly. Thank you so much.
Thank you very much, Ramesh. Am I audible?
Yeah.
Thank you, Ramesh. I think Ramesh has showed us the limits of an OCT. For the general ophthalmologist, my message would only be, there's a lot we can do. If you feel that your patient is not looking completely normal, don't try to get into these details. This is a bit on the higher side for a general ophthalmologist. In fact, this is the kind of case, this is the kind of situation where you should refer the patient to a specialized center where they can use the latest OCT techniques. Because remember, what he's shown you, you're not going to see on a Stratus. You may not even see him on some of these of the spectral domain OCTs. You need to have the latest technologies available, and there are a lot of things that are becoming visible to the naked eye through the use of this technology. So I think all in all, the basic point which was made is, when in doubt, please either, first of all, do a fundus examination yourself, do an OCT yourself, where everything is not explained, where you cannot build up the entire story of what's happening to this patient. Send to a retinal specialist and let that patient have the benefit of whatever technology is available today. With that, we can give the best to our patients. We've actually run out of time. I don't think there are many other questions. No, I haven't been given any other questions after this. And so I must thank you all for being here, and for AIUS for providing this forum for this series of lectures. I think we've had a wonderful interaction. everybody has contributed greatly to the success of this meeting. And thank you very much, everybody. With these few words, I want to say bye-bye. And good day. Take care.
Thank you, sir.
Thank you, sir. Thank you so much.
Thank you.
Thank you, everyone.
Thank you,
Have a
everyone.
nice day.